So we go into this health facility, and there's this 9-year-old girl. They have delivered a baby as a result of defilement. The perpetrator is the father, and she's infected with HIV. When we talk about gender-based violence, I wish we could discuss it wholesomely.
Okay.
From the psychological effect that it has on both the survivor and sometimes even the perpetrator. The issues around men and health-seeking behavior and seeking support and getting supported are more cultural than really systemic. Men are not able to seek help. Men are not empowered to speak out. Men are not empowered to know that it is okay. Yes, my wife is violent and I have to be supported. And studies have shown that about 50% of the people who are living with HIV are likely to also living with a concurring mental illness. In Kenya, we have about around 1.4 million people living with HIV. 800 of them are women.
Welcome to Manspeqtive Africa, your favorite show. I'm your host, Dannish Odongo, aka the son of Kano. And of course, we are always live on KTN Wednesday every night. And if you're watching us on YouTube, make sure that every Wednesday night you're tuning into KTN to watch our content. Of course, if you're watching us on KTN, we are on YouTube. The channel is Manspeqtive Africa, and I'm Dannish Odongo across all social media platforms. This is the month of May, and we are having conversations around mental health awareness. Of course, May is the month that we talk about mental health. And of course, we talk about many other things, but mental health, we really get it and we don't really talk about it. And the person who's going to help us make sense of this conversation is none other than a psychologist actually. Her name is Stella Gitia, who's coming from LVCT Health. She tells me that they rebranded and it's not the Liverpool that we knew before. Stella, welcome to the show.
Thank you. Thank you so much, Dannish.
Asante sana. You're telling me that you're the mental health program manager at LVCT Health.
Yes.
That sounds like a very important role.
Well, if you say so.
Yeah.
Yeah, but yeah, it is. It's an important role in this era where we are talking about mental health.
All right.
And the mental health needs across the globe.
Across the globe.
Yes.
All right. So as we start, maybe perhaps it is you who knows really how you can define yourself. So maybe perhaps for the sake of our audience, you can tell us, what did you study, or what's your career like, and what do you do at LVCT Health, even though we know that you're a mental health program manager, but how does that look like on a day-to-day basis?
Great.
Yeah.
So I am a trained counselling psychologist and a social worker. Yeah. But then I went on into program management. Okay. So I've spent quite a lot of my career years, over the last 20 years, managing programs, HIV programs, gender-based violence programs, mental health programs. Currently, I'm managing the mental health program at LVCT Health. Okay. LVCT Health is a non-governmental organization locally here in Kenya. And for the last 22 years, we've been really mandated to provide technical assistance to different partners, including the government through the Ministry of Health and even other ministries, just to develop programs that are targeting vulnerable populations, hard to reach populations. So over the years, we've done quite a number of things, including HIV prevention. We were the first people in Kenya to bring in HIV testing.
Wow.
The VCTs, what we used to call the voluntary counselling and testing centers. That was LVCT's brainchild.
Wow.
So, and it has grown over the years, and now everybody now talks about HIV testing, but it started with us.
With you guys.
So we can proudly say that when it comes to HIV testing and HIV prevention, we know quite something. Yes.
And I'm glad, because I think part of the thing that I love is to get like reservoirs of knowledge. So if you've done it for 20 years, then I know that what you'll tell me here is not just theory, but also it's practical, you know.
Yes.
So, okay, let's start from the basics, you know. How do you understand, and I don't want to make it like a conversation, you know. So you've done work around GBV, you've done work in HIV and AIDS awareness as a programs manager, you know. When we talk about gender-based violence, we don't really talk enough about the mental health bit of it. I think we are just talking about the crime part of it.
Yes.
How does that make you feel, or how do you see it?
When we talk about gender-based violence, I wish we could discuss it wholesomely.
Okay.
From the psychological effect that it has on both the survivor and sometimes even the perpetrator. The legal system, the legal journey, the health journey, because it's something that is going to affect somebody very differently. If someone has experienced violence, they're emotionally affected. Their feelings are affected, their trust is affected, and especially when we talk about gender-based violence, where the perpetrator is someone that is very well known to this person. If it's between intimate partners, this is someone that this person loved.
Yeah.
So there are issues of trust broken, there are issues of really betrayal. So we may not only want to focus on, yes, it's a crime, but how do we support this survivor? How do we ensure that their emotions, their psychological well-being are well taken care of? And I like the fact that when we come to responding now, even through the healthcare facilities, the survivors are provided with a comprehensive package that includes both looking at the medical issues, that is, of course, ensuring that they do not pick HIV, they do not pick a pregnancy, an unwanted pregnancy, they do not pick an STI, so that is managed. But again, also there's the mental health part, which again brings in the psychological counselling.
Yeah.
And the trauma counselling as well.
Yeah.
Yeah.
I usually feel frustrated that most of our interventions are on the tail end of the problem. So, for example, we are saying, let us have survivors' houses, safe houses.
Yes.
Let us pass the law to criminalize. And there's nothing wrong with that, But what, in your work that you've done for 20 years, why do you think that men perpetrate gender-based violence? What would you understand as a psychological reason for some of these things? It's not to excuse, but it's to understand based on the work that you've done. Yeah. Yeah.
Thanks so much for asking me that question, because I think that is something I've always pondered about. And I remember when I was in school, I did a study in prison. My study was on criminality amongst women, just trying to find out, women are supposed to be nurturing and kind. What is this that drives them into crime, and sometimes even very serious crimes? And I was able to do that. But then after I got my findings and really found that it was just around the socioeconomic issues, a woman would steal because they want to feed her children. A woman would get into a gang because they want to get money and support their family. So I started also getting curious about now the men. And even when I was working in the gender-based violence space, my interest was on why did this happen?
Yeah.
This is a father who has defiled a child. And I remember one very traumatizing experience I had in one of the counties. I won't mention the county, but we work in around 34 counties in Kenya. So we go into this health facility, and there's this 9-year-old girl who is in the maternity. And the nurses call us and tell us, so we were just going to provide supervision and technical assistance. And the nurse tells us, there's a young one here, we don't even know what to do. So this is a 9-year-old girl. They have delivered a baby as a result of defilement. The perpetrator is the father, and she's infected with HIV. So the nurses don't even know what to do. And I started asking myself, why would anyone do this to their child? So I like what you've asked, because I don't think that is something that anyone has found an answer. Why do perpetrators do this? And probably just need to continue doing. But now the other thing is, because of the legal perspective, I don't know how it would be if perpetrators now have to also be put through the process of explaining and even being followed up to know really what are some of the psychological issues that led into this. But you see the way we look at it, you're the perpetrator. Go to jail and let us support
The survivor.
The survivor. So I wouldn't really have an answer to that. But again, different studies have shown different things across the globe. Some of it is just around the psychological issues, advanced childhood experiences, probably previous experiences, trauma experiences. Yeah, so some of those things is what really would lead someone into such an act.
And some of these things are actually also deeply cultural. I know of certain parts of this country where if a woman is married into a home with a daughter who is not who's not a biological daughter of this man, chances of this man, trying to make a move because they don't think that they are related, but also even to get back to the woman happens a lot. And it's not to excuse really this thing. I personally think that the level we've reached with gender-based violence and the conversation around femicide, I think what might help us is a truth and justice reconciliation type of approach. Remember that in a place like South Africa, if they decided that they're going to use the law to to really deal with the challenges that South Africa was facing, we're talking about the perpetrators of apartheid, but even the poor responding against apartheid, it was going to be like a zero-sum game.
Yeah, sure.
I feel like how we are working on the gender-based violence space as we speak right now is going to be a zero-sum game. Because we're not spending a lot more time to understand how do we go downstream to stop this from happening. Are we going to put resources into studies? Because we have excellent universities like the University of Nairobi. We have Masinde Muliro University. Every part of this country has a university. And I'm wondering why the government is not putting even a small percentage of their 4 trillion budget to think about how do we stem the tide? Because even when the government released about 100 billion shillings by the president to do the gender-based violence, I don't think a lot of money is spent in understanding why this thing is happening. Because I think if we understand the cause, we will stem the tide. Because Stella, if we want to deal with cholera, we first of all find out, are there polluted ponds, are there polluted wells? Can we first, so there's a public health component of it, there's a personal health component of it, there's a psychological, social, HIV intervention is, at the beginning, it was mostly seen as a medical issue until we realized, it's an economic issue, it's this issue, and ultimately we came together and we built such a holistic way, and HIV new. In fact, you'll tell us more about that. But I think we've made more progress about HIV.
A lot.
For you, who's work in the gender-based violence space, but also work in the HIV space, what do you think we should do so that we don't end up with just reporting the cases, but we are also preventing? Because I think the work we need to do also is preventive in nature.
Thank you so much, Dannish. And I like your question. And one of the things that we've really tried to push and really work on is the prevention of gender, of how, because if we wait to respond, it's normally very complicated. So for us at LVCT, we are looking more on in terms of how do we prevent, and how do we even ensure that even the people who are more vulnerable to this violence are able to know what to do in case they experience the violence, and especially for violence that is domestic related and partner related, intimate partner related, because that is where now it becomes even very complicated. So we've tried to do a lot of capacity building, and especially for the providers, the healthcare providers, not only to wait to respond, but even as they're doing everything else, are they able to provide information? Are they able to provide support to people who they feel are vulnerable? And especially for issues like domestic violence and intimate partner violence, currently in all the facilities across, there's going to be screening for violence. Like the healthcare provider will ask questions, about 3 questions to anybody who comes in and they feel probably this person could be experiencing violence. Because again, we know people may not even come and report. Most of the people don't come and report violence. So again, the providers now have been trained to inquire. If you come to my clinic, I will ask you, maybe you've come for other issues, you've come for malaria, you've brought a child to the hospital, but I notice you do not look okay, you don't look stable, you don't look composed, probably you even have a scar, then the healthcare provider will ask, I want to ask you a few questions about violence. Many people experience violence, and I would want you to tell me what you think about this question. So I'll ask you, has anyone hit you in the last 2 weeks? Has anyone spoken to you in a way that probably you felt like they were abusing you? We even ask about sexual violence. Has anyone done anything to you that you feel, anything you felt was not appropriate? And that now creates an opportunity for the person to say, yes, this has happened to me.
Yeah.
And again now, if depending on now how far it has been happening, the provider now is able to support them. And if there's any need for them to be maybe removed from that environment, then now we go to the other players who are able to do that. So again, that is an area that we're really focusing on. Just ensuring that we don't wait until we've been called and someone's hands or head has been chopped off. But over the time, as someone is accessing healthcare, there's that kind of inquiry that again helps them talk about their experiences.
Do you feel like there's enough support for men, especially to equip them with alternative ways of dispute resolution, alternative ways to deal with how they feel? Or do you feel like a lot of effort is being put on survivors, which rightfully so should be done? But how are we, do you feel like we're supporting men enough?
I know that really comes up a lot. And what I would want to say is the issues around men and health-seeking behavior and seeking support and getting supported are more cultural than really systemic. Because for men, I know men are raised to be,
Stoic,
tough.
yeah.
And so sometimes you find it very difficult to even know what would be done to really support the men. And I want to talk about even accessing healthcare. And I want to talk about accessing HIV services. I want to talk about accessing violence services, because even men are experiencing violence. I want to talk about accessing mental health services. The cultural man, or the way men have been raised in our culture, is that men are strong. Men don't. Those small things are for women. Women are the ones who go crying when they have been beaten. Women are the ones who go to the hospital when they cough. Women are the ones who are always, that's the narrative that we have been raised. And even in our families, and I can tell you for free, in my family, we are 5 of us. We are 3 girls and my 2 brothers. But I could see even as I was growing up, even if there's a sickness, by the time my brother is really seen to be sick, they've really become sick. But my mother would be very worried if the girl is not very well. Because if my brother would say, I'm not feeling well, I know you don't want to go to school. Wear your uniform and go to school. Yeah, so that, and then the man now will be pushed a little bit harder. Just push it a little bit harder. You're a man. Why are you crying? Like your sister, So those things have now created a problem because men are not able to seek help. Men are not empowered to speak out. Men are not empowered to know that it is okay. Yes, my wife is violent and I have to be supported. Yes, I am struggling mentally. I have to go and seek help. And the other thing is, for women, it gets easier because women, again, talk a lot about their issues. Men are not easy to talk about their issues. And I know they have all these social groups, they have all these social things that they do. But you tell me, how often do you talk about what you're going through in your personal life, the boys in your boys' club?
I think that's a very good question. Men don't talk a lot about their issues, but it's not like men don't talk. It's that men talk in specific
Spaces.
circumstances and spaces.
Yes.
And so I think if at all we care about a half of the population in this country, then we'll ask the hard questions that, okay, how then do we reach the half? So then we design programs that would meet this half. But because I think our healthcare system, I would honestly say it's feminized.
It's very feminized.
So it's difficult to, to design programs that would meet the needs of men, because, men are, in my opinion, very dispensable.
It's true.
Our death is almost expected. When we are dealing with addictions, we are blamed. But hapo,
And men suffer more.
Yeah.
Men suffer more the consequences of some of these things.
Yeah.
And I like what you've said. What are those spaces? And what have we done to get into those spaces?
Yeah.
Because we may not really get much by just doing the routine things that we've been doing. We need to get out of our comfort zone and ask ourselves, where are these men? And I remember when we were doing the HIV programming, initially, we really struggled with reaching men, and would go out everywhere, put up tents, advertise, mobilize, go around with a loudspeaker talking about the services, but the women will come. And the men will not come. But the men will be sitting somewhere at the side. And if you happen to go to talk to them, they have all these questions. They are curious. They want to know what's happening. But they are not sure they want to come where you have put the tent.
Yeah.
So we started coming up with all these men-friendly initiatives that would make them come in for HIV testing. And some of them are even things like sending the women with a HIV self-test kit to go and take to their partner. And that has been seen to have a bit of result, and especially the ANC mothers. When they come to the ANC
mothers?
Antenatal clinic,
clinic mothers, okay.
They're given a strip to go and take to the partner. There are clinics that would even write a letter to the man and tell them, please come and see me. And when this man comes, you don't start with HIV. Yes, you start with blood pressure, you start with lifestyle, how have you been? Have you been checking your blood pressure? How is your weight? Can I take your weight? Can I take your blood pressure, blood sugar levels? You get into that conversation, and then now finally talk about HIV testing. And that bore some result. And then there are those programs that would just be very specific for the men. I remember one time we were working in the upper North Isiolo, Moyale. And because of the cultural differences, you cannot just tell a man to come to the HIV clinic for a HIV test. You cannot tell a man in upper North to accompany the wife to the hospital. So you have to look for very innovative ways of reaching these men. So would set up a ceremony, like if they're having their traditional or cultural ceremony, would join in and have people doing the HIV testing. And they were really happy that we are able to even come. So they are chinjaing their mbuzi there, and there's a HTS provider there who is giving them information about HIV and testing them. So like you're saying, we have to look for ways that really have to go into those spaces that men are. Because one thing that I like about men, if you go to their space, they will let you in. But if you're here and telling them, come here, then that sometimes becomes problematic. But I like the new things that are happening. Even people are even using technology to reach men. You could even have WhatsApp groups and really just give a lot of information. You could even have virtual support groups where men can just come in and listen, and then someone will come up and again. But again, in terms of accessing services, because we run counselling services. We have a counselling services known as Wema clinics, Wema counselling clinics in town, and both in our offices on Gong Road. But you realize the number of men who come for the services are fewer. And men may only maybe come in when it's a couple session. So again, what we are talking about now is how do we get into those spaces where men are comfortable, men are free, and they can talk. And I like something you said about the health facilities being looked at as feminine spaces. Men are not patient enough to go and queue the whole day at the hospital, because you need to go and and work. I mean, so some facilities would maybe adjust the hours, like men can come in earlier, then they go to work, or they can come in later in the evening when they come from work. They can come in over the weekend. And some of the HIV clinics have really succeeded very well in doing that. You don't give a man an appointment at 11 a.m.
Yeah.
That man is supposed to be somewhere looking for bread for his family.
Yeah.
So again, that also has really helped in ensuring that we're able to reach most of the men. But again, a lot needs to be done. I really totally agree with you. A lot really needs to be done so that we have a larger reach.
Yeah.
We have a wider reach.
I also think that another problem that makes the interventions mostly targeted towards women is because of donor reporting.
Yes.
Because women are likely to respond, women are likely to uptake, so the donors have this ability to report to their donors, we reached 5,000, but men, if you're going to spend 3 months just trying to design the intervention on how to reach them, that time the donor wants a quarterly report already,
Yeah,
So
sure.
I think also that's also, we need to rethink. And it bothers me that the gender-based violence issues to do with health are mostly left into the hands of donors.
Yes.
And I'm wondering how you feel about that, especially that you work for an organization that receives quite a bit of donor funding. How does that sit with you?
I will tell you, it's not been easy.
Yeah.
It's not been easy with all that is happening. I'm sure you're aware of all these donor fundings.
Yeah.
And what the challenge we are having now, and especially as a local organization, is how do we even start looking for resources locally? Because one of the things about some of these activities that we do, they can be funded locally. But it all depends on what are the priorities. And so we're looking at solutions that are just homegrown. We have organizations, we have companies, we have big farms that can support some of these services. And for us at LVCT, we were able to also come up with now almost a business development that again looks for resources, charging some little money, so that again we're also able to give services which are sustainable, are subsidized, because we realized from a very long time that this was going to come to an end.
Yeah.
Yeah, but again, like you've said, how it sits with me is that we need to do more resource mobilization locally and
also
allocate budgets locally.
But also fundamentally, it is a philosophy problem, because if your health needs lie in the hands of foreign players,
Yes.
then they will push their agenda.
Yes.
They'll push their priority areas.
Yes.
And that can, affect how we report, because maybe the issue could be malaria. It could be the one thing that is killing many people. I'm just giving an example.
Yes.
But then we can put a lot of emphasis on this specific thing because this donor wants this specific thing done,
Sure.
And so at the end of the day, as a journalist, then the framing and what screams on the headline are the things that these people want, but not really the reality.
Yes.
Let me give you an example. I think that we know that femicide is an issue in this country. And I was asking people, and I ask everybody who come here, that do you know that 80% of deaths on our road are men, especially Nairobi?
Yes.
80% of deaths on our road are men.
Yes.
But we've never asked ourselves, how would roads look like if these roads were to be built for men? We never ask that, because when we talk about gender responsive spaces, we always think about women responsive spaces. We don't think about men. And that doesn't sit well with me, because honestly, as a Christian and as somebody who believes in holistic wellness, there is no way we can push an agenda that favors one gender in a population where they are 50-50. It's like you're saying that, if 50% of these people are well, then 50% of them would be automatically well. But by ignoring 50%, you're almost saying that, okay, even the 50% we're doing for the 50% will not, help these ones? I don't know whether you are a mother. I don't know whether you are somebody who's open to this.
I am a mother.
How do these things make you feel?
I am a mother of a son and a daughter.
Okay.
So
you understand this thing.
Understand,
Yeah.
When it comes to issues to do with gender, I would say they're complex issues. Because one of the things I think is we got to a point where now we started pulling, instead of pulling together to just see what really works for everybody, we get to a point where probably everybody now starts pulling their own direction. But from where I sit, and I know sometimes issues to do with gender are issues that may be looked at as women affairs and women issues. But when we talk about gender transformative interventions, gender responsive interventions, I think it's important that we look at both the male and female. Because if we don't really put in, because we coexist, we are families. And you find in families, we are all there together. And one of the things that has really come up, and this is not really something that I would say is research, it's just my own observation as an individual now, even not talking on behalf of anyone. I've realized we did quite a lot for the women. And the women really got empowered. And now it's becoming an issue. And so what is it that we can do so that we don't really even escalate this further? You find, and I have a son. I know the struggles he could be having even in getting into relationships. Because the people he's trying to relate with could be way far beyond. Yes, he's gone to school, he's got his bachelor's, he's got his master's, he has a job, but the expectations from the other side are, I want to holiday in Paris, I want to, and the young man is just struggling and living in a bedsitter somewhere, and then someone starts telling you about Paris. So some of the things that we really may have lost track, but we really need to come back and ask ourselves, where did we lose it? Where did we leave behind this other gender? Are we able to now come back together and say, these are the needs for the male, these are the needs for the female? Yes, the female are vulnerable.
Exactly.
And that is the word around. Everybody would look at women as vulnerable. But again, we may want to start now segregating. Is it all women? Is it a particular set of women who are vulnerable? So that again, even as we are coming up with interventions, we have that at the back of our mind and we're able to support across board. Because you find in the rural areas, there are men who are even more vulnerable.
I always use this example. I'm Luo. Ruth Odinga is a woman. Ruth Odinga is younger than me. Between Ruth Odinga and I, who is vulnerable? Certainly it's me. So we cannot say that only your gender is what makes you vulnerable.
Sure.
We need
there
to look
are
at
other factors.
Socioeconomic. Socioeconomic is the real is what makes you vulnerable than even your gender. Because if you're a poor man in the informal settlement of Korogosho, a young woman in Kilimani or in Kileleshwa is more privileged than you are. Because the challenges you're facing there in Korogosho are very different.
And even the expectations from the society, because the society expects you're the man. And we've seen even some of these issues, even when it comes to issues. And some of these are the issues that will lead to gender-based violence. Because the expectation is that you are the man. You are supposed to provide. So even if your wife is doing better than you financially, you're still the man. That's what the society expects. So again, those variances now make...
and when you cannot provide, now that you've been told all your life that you can provide, then what happens is that you will provide violence. Which, because you're stronger and you're frustrated and you will met it out on the weakest. That's not to justify that, but that's to say that we got to think about interventions that think about people. But I believe that women still need all the support they need.
Yes.
If you look at teenage pregnancies, if you look at child marriages, if you look at
the burden is
more
on
on
the
women, you know.
Yes.
And even if you look at just the level of men who are successful,
yes,
they still considerably hold power more than women. And the idea is not to take away power from men to give them to women. The idea is equity, you know. So I think we need to still do this work.
Yeah.
But even as we do this work, we need to also do this other work. Because people have this problem of what I call a very linear thinking, that it can either be or.
Yeah,
it can be
sure.
both. We
Yeah,
can
it can
do
be both.
interventions
It
for
can be
men
both.
and do
It can be
interventions for
both.
women.
Yeah, and I desire a place where we are now looking at both, because I've told you I'm a mother of both. I wouldn't want one to be lesser than the other one.
All right.
So
Also, language really matters how we talk about these things. I always hear people saying that, oh, during war, you know, oh, you know, the war in Gaza is so bad because they're killing women and children. But I always say that, okay, so when you kill men, it's okay. Like, it's absolutely okay that, oh, we've killed 1,000 people, but, you know, it only becomes an issue when a considerable number of them are men, are women, rather. And I just wanted to tie that to the previous conversation we were having. But we're coming back to the health-seeking behaviors. Apparently, I was reading somewhere that the HIV statistics are interesting, and there are gender dynamics about them.
Yes.
Maybe can you share some of them?
in Kenya,
Yeah.
we have about around 1.4 million people living with HIV.
1.4 million people.
Yes.
Yeah.
And about let me say 800 of them are women, and the rest are men.
So more women have HIV
Yes.
than men.
When it comes to prevalence,
Yeah.
the country prevalence currently is 3.3% as per the last estimate, that is 2023.
Yeah.
And for women, it is 4.4. For men, it is 2.1. When you talk about new infections, of course, women have more new infections than men. And when it comes to HIV-related deaths, now the men die more from HIV.
So we are almost looking at out of 1.3, out of 1.2, 1.3, we're talking about almost 800K of them are
Yes.
women.
Yes.
But more within this category of men are men are the ones who die more.
Yes.
Yeah.
So that is an area for concern, because if we are able to have less men if are infected with HIV, why is it then they are dying more than the women?
And what is the data saying? What are the stories saying?
And the answer behind this is very many issues. And I spoke about the cultural aspect. First of all, when it comes to seeking HIV testing, there are more women who will be tested. I think in the last statistics, and I can just quickly check my notes. In the last 12 months, when you talk about testing or accessing testing, 39% of men said they have been tested for HIV. 47% of the women had been tested. So you see, for men, they are testing less than the women. And one of the issues that really we have struggled with, I spoke about me being in the HIV field for quite some years. Men have low perception of risk. Yes. Men have a very low perception of risk when it comes to HIV. And I'll tell you what, women, and especially women of childbearing age, currently as per the national guidelines for HIV prevention, will have to be tested several times. If a mother comes to the facility and they are pregnant, they are tested. Fourth visit, they are tested. Post-delivery, they are tested. 6 weeks after delivery, they are tested. So the woman will be tested every other time. When will the man be tested? And the issue about low risk is, and I have had conversation with men. I like talking to men every time I get an opportunity, just to hear what are their perspectives. Because as a programmer, I wouldn't want just to be talking from, I want to hear what is this. So when I get into a cab, I'll talk to the Uber guy. He'll ask me, where are you going? What do you do? And we get into a conversation. So someone will tell me, me, I can't be tested. Nilipimwa siku moja na sitawaipimwa tena. Sababu hiyo siku moja nilikuwa sawa. But you're like, but you could be having other risk. Hata bibi yangu alikuwa hosi, tuko na mtoto mdogo, alipimwa na ako sawa.
Why do you think men have a low perception of risk when it comes to HIV? How does that manifest? What do you think causes that?
I think I would just put it in the whole idea of the trauma of being diagnosed to have HIV. Because, of course, the fear of getting HIV is still there. Much as people would say, oh, we have ARVs, oh, people are living long, oh, no. The fear of being diagnosed with HIV is still there. And it is more with the men than with the women. Because, again, the women have a support system. And sometimes the society is more forgiving to the women. And you'd hear women saying, oh, unajua sisi wa mama huwa tunaletewa hii kitu. So the society is more forgiving to the women. But a man would fear, what am I going to tell my people if I find that I am HIV positive? What am I going to tell my partner? You see now that fear of, how did it happen? How did it come to be? So a man would rather say, I would better not know than know and get into problems. So more the fear, the stigma around HIV status, and even the inability to access the services. Because for the women, they know, if I get tested and I have HIV, si hata naonanga watu wakipewa madawa hapo hospitali, the man may not even know that in the hospital drugs are being given out. So that fear of knowing, the fear of accessing services, and of course the cultural, the male ego, like, I can't do those things.
Oh my goodness.
And of course I have told you, they will say, my wife gets tested and she's okay.
So I'm
okay. Yeah. But we know they're discordant couples. Yeah.
Oh my goodness.
We know they're discordant couples.
And these men who eventually get tested and are there to and then start medication, are there major differences between how women are there to medication and how men are there to medication? Are there massive differences?
Oh yes. Oh yes. And I'll start all the way from even starting treatment, because after you're tested and you have HIV, of course, you're started on treatment. And nowadays, it's just immediate. Same day, you've been tested, you've been confirmed, you start your ART treatment. That, again, is a problem for the men. And when we look at linkages rates, and of course, like now, we almost have 97% of the people who have been tested to have HIV on treatment. But we find that the men will be lower. The rates for linking men to treatment will be lower than that for women. And there's something we call tracing. If someone doesn't come for their appointment, you have to go look for them. It's more difficult to bring back the man to the clinic because of all these issues that I have spoken about. And those are now the things that make it very difficult for men to really get into the system and get treated. I spoke about the clinic hours. Most of the clinics, again, will open between 9 a.m. to 5 p.m. That time, men are not available. We have men traveling all over. But again, nowadays, I like the way the government has put in systems that you can take your ARVs from wherever you are. You know, initially you had to go back to your clinic. But nowadays, if you are in Bungoma and you run out of ARVs, you can just walk into any clinic and get your ARVs. Yeah, so that has made it a lesser burden for the men. But again, still, we now come to the adherence to treatment. Yeah, there's still an issue around adherence to treatment with the men. And because of the same issues around fear, stigma, some of them have not even disclosed to their partners. So you find a man is on ARVs, their partners don't know that they're on ARVs. So there are times that they're not even able to take their medication. Lifestyle, sherehe. It's a Saturday night. I'm supposed to take my ARVs at 8 p.m. 8 p.m. tuko wapi? We are out, hanging out. So am I going to leave people on the table and tell them I am going to take my ARVs? And sometimes I will leave and forget. And maybe probably remember on Monday. So again, adherence for them is an issue. And even when you look at the viral loads, for them, they are always struggling with their viral loads. So in terms of adherence to treatment, men have been having a lot of struggle. But again, I like what we say, that we have to really look at what is that works for men. And I'm happy that nowadays we have the differentiated service delivery model, whereby you can take your ARVs for even as long as 6 months. You don't have to be going to the clinic every other day. And that has really worked well for men. It has worked magic for men. We have the group, the community groups, whereby we don't all have to go to the clinic. One person we can get into a community group. We are 10 of us. We know this is where we pick our drugs. We pick our drugs at Mbagathi. So, Dannish, this is your month to go and pick our drugs. You bring them to us. Next time it's someone else. Next time it's someone else. And that has really helped in terms of adherence, because again, the monthly clinics was also burdening quite a number of people who are accessing treatment. But again, the issue of the whole issue around their mental health and accepting that they are HIV positive, the whole idea of lifelong treatment and medication, again, becomes a factor for them to really get tired of the whole discussion. But we've seen quite good progress,
Part of the reason why we are very keen on asking these questions, because majority of our audience are men, and they listen. And we talk about a lot about the manosphere. The manosphere are the spaces where men talk. You know, there are people who live the manosphere. And they talk about the traditional expectations of masculinity. And maybe that is what they need to do, and that's their passion, and I have no beef with that. But I think we don't have enough spaces where men are being equipped with information, like in terms of health-seeking behaviors. How do we deal with the challenges that we're facing around identity? And that's why when I heard that you actually do this work, I said I will host you. So tell us about the impact. Why is the government really insisting on people, to seek interventions and to be tested, and to what would an undiagnosed or an untreated or an unchecked HIV amongst men be to the population or to Kenya generally?
Of course, undiagnosed infection would mean more transmissions and more infections. And the way HIV is transmitted, and of course, it has a lot to do with even the biology, the biological creations of
the anatomy,
the anatomy of men and women. Men would spread more than the women, because a man would have multiple partners. And so if a man has HIV, they're likely to spread HIV to several women.
So women don't have multiple sexual partners?
They also have multiple sexual partners. But again, for the man now, if they have the HIV virus, if they have intercourse with several women, chances are that a number of women from that relationship will pick the virus. But when it is the vice versa, it's different. A woman would have multiple sexual partners, but the chances that all those sexual partners who are male are going to pick the virus is lower. But then now the conversation around men now being really not the ones that have the virus becomes another story. So again, what do we need to do to ensure that we protect everybody? But what I want to say, and just to answer your question, is as a country, I know we've made quite some progress in terms of prevention. And some of the technologies, again, for prevention would favor women than the men. I know currently we have the oral PrEP, which is good for both men and women, but you find that it's more targeted towards the women. Unless someone is really part of what is happening, not many men even know that there's something called oral PrEP.
What's oral PrEP?
Oral PrEP is...
I know PrEP is prophylaxis thing.
Yes. Oral PrEP is now you take orally. So oral PrEP is normally taken for all the time, but nowadays we have event-driven PrEP.
Okay.
Which again now is working for the men.
Tell me more about... So PrEP is PrEP at a pre...
exposure prophylaxis.
Yeah, so you take it before you're exposed.
You take it before you're exposed.
So oral, so it's available for women.
So it's taken orally.
Yeah, it's available for both men and women.
Yeah, for both men and women. But now the push, and you remember what you said, the donor target and the donor push is more for the women. Because mostly the people who are like really priority are the pregnant and breastfeeding women and adolescents and young girls and sex workers, the female sex workers. Those are the ones that basically would really be pushed to the PrEP.
Let me just think about their reasoning. So perhaps for these mothers, it's to minimize the risk of transmission.
The mother-to-child transmission.
And are adolescents overly, are they more sexually active than the general population amongst women, or why are they targeted?
You see, we are looking at prevention for the adolescents and young girls, and especially the vulnerable young girls. We spoke about the korogoshos and whereby a young girl would have sex for even basic
sanitary
towels, food for the family. So again, that's a population that has to be prevented in most of the programs. Yeah. But I was talking about the event-driven PrEP, whereby a man will take 2 tablets before, maybe 2 to 24 hours before exposure, and then another 1 tablet after.
What do you mean before exposure? That's a very
Okay, Dannish. Let's put it as it is.
Thank you.
Today is Friday.
Yeah.
Dannish has a date on tomorrow, Saturday, maybe around midnight. I want to put it so that the hours make sense, because of course, with hours, the more the hours, the more the efficacy. So it's 2 to 24 hours. If you take it 2 hours before, you're good. If you take it 24 hours, you're better, right? So the man will take these 2 pills, the PrEP 2 pills, go have their thing, and then after that, take another 1 pill. So the issue here is it reduces, it does not completely stop you from getting infected. It reduces the chances for you getting HIV. So if someone was using a condom and probably the condom bursts, then this person is better off than the one that did not take the PrEP. Yeah. So again, but how popular is this amongst the men? I'm sure you've not heard about it, and you are a man who is exposed.
Maybe because I'm a Christian and I'm a good man. I'm kidding. It's on a light note.
Yeah, you see now you have a channel which again you could use to send out this message to the men, but you don't know about it. So those are the issues around prevention for men. The information doesn't get to them the way it should. So there's quite a lot.
I want to challenge you that part of what I can help you do is that there must be intentional awareness around male spaces. So, for example, there's the manosphere.
Yes.
So I think it's important that we actually, get this out and get people who are in this space to literally talk, because this is a life-changing information.
Yes.
But they say that proper condom use is more efficient than any other method of HIV prevention. Is that true?
Oral PrEP has more. The PrEP has been. I can't remember the exact the percentage for efficacy, but it's better than the condom. But those are the studies that have been done in general population.
What do you mean by it's better than? See, I've thought that if you use a condom properly, chances of infection are low. Used properly. We are saying when it's used properly, it's extremely high.
The using properly is now
the issue.
The issue. Because condom is consistently correctly.
Yeah.
That is where
consistently and correctly.
Yes. Yeah. Correctly and consistently all the time.
Yeah.
I have told you, I talk to people. Many people will use correctly, but not consistently.
Yeah.
Others will use consistently, but not correctly. Yeah, so unless you're able to really just combine correctly and consistently. Yeah. And you know what normally happens?
Yeah.
Day one, condom.
Yeah.
We are not talking about it. We will wait. We will send a boda mpaka alete. Day 2, okay, yeah.
So you
say
so tell me,
kitu usilete.
So for this oral prep, so that my audience gets it, it's important if you take it 24 hours before.
2 to 24 hours before.
2 hours to 24 hours.
Yes. But again, I said, the more the hours, the more the efficacy.
The more the efficacy means, the more effective it is.
Yes.
Okay. So which means, okay, sasa basi. Mnasikia maboy, by the way, on the game, pick one.
Yeah.
Are these offered? Where are they offered? Are they free?
Within the health facilities, and they are free.
They are free.
Yes.
But you have to be tested first before we give you.
Yes, you have to be tested. You have to be HIV negative for you to get PrEP.
Okay.
Yes, you have to be HIV negative for you to get PrEP.
Now, wametupangia, we have to go and get tested, all right?
Yeah.
So somebody might wonder as we come to an end of this show.
And again, let me add something before we move on. And this has really helped with the discordant couples. Yeah, the PrEP has really helped with the discordant couples. Because again, now it really reduces the chances for the negative partner to get infected.
Yeah. Somebody would wonder, why are we talking about HIV in the mental health month, especially for men? So maybe you can tell us if there's a correlation or whether this is just a misplaced, conversation.
There is a correlation.
What is the correlation? Yeah.
One of the things that will happen when someone has a HIV diagnosis, they will totally get to think about it. And when we talk about mental health, we talk about thoughts, feelings, and behavior. Yeah. So if I get tested for HIV today, I start thinking about it. And these thoughts would even lead to me feeling angry, me feeling useless, me feeling hopeless. And that would even lead to other behaviors. If I am going through a mental health condition, like if I have anxiety, if I have depression, I may put myself more at risk for HIV. So the two are very interrelated because one would lead to another. And studies have shown that about 50% of the people who are living with HIV are likely to also living with a concurring mental illness. So again, this requires us to really push for screening for both HIV and for mental health. If someone has a HIV status and they start taking medication, the process of even disclosing to their partners will cause distress. And sometimes we make the clients even practice how they are going to go and tell their partners that they have been tested for HIV. And someone will come back and tell you, yo kitu inani stress. Mimi sitamwambia. So you see there's a distress here. I haven't told my partner that I have HIV. So if this is not addressed, it could continue and even go into an anxiety issue or a depression issue. So, and one of the things that we keep talking about is that for us to really achieve good health, because we always say there's no health without mental health. Yeah. We have to put mental health in all the spaces. And I'm happy that mental health has now started getting a space. Where mental health is now is where maybe HIV was a few years ago. A lot of stigma, a lot of fear, a lot of hush tones. If I come and tell you, I don't think I am okay. Ambia we wacha hizo zako. We wacha hizo zako.
Yeah.
So again, the talking has to continue. The stories around how we are feeling, the check-ins have to continue, and especially for men. Because again, even when it comes to mental health, the seeking behavior for men is still the same. And I know this month of May, where we are having the mental wellness awareness, we really need to really talk a lot about it. And in June, there's the men health month.
Yeah.
I wish mental health can now be something that people talk about, because you realize if we don't talk about these things, people are perishing. We don't want to wait until someone has psychosis. By the time someone develops psychosis, they started with anxiety. We didn't see it.
Yeah.
They probably got anxiety and depression. We didn't see it. So how are we able to talk about mental health in all these spaces? And I'm happy now that even the Ministry of Health is really pushing to integrating mental health within the HIV spaces. And we've done a lot of capacity building for the healthcare workers, like I mentioned earlier, so that every healthcare provider in the HIV clinic is also able to screen for mental health and also provide some sort of support before referring now for the specialized services.
Wow, Stella Gitia, thank you so much for such an enriching conversation. You have given us really, I think, life-changing nuggets just about health, because I think one of the major issues men face is in their area of health, and when their health declines, then they lose meaning. So why am I living? What is important?
That's true.
So it's important that we equip men, especially with this HIV and AIDS and how it relates with their mental health.
Yeah.
And of course, it is Manspeqtive, your favorite show. I'm your host, Dannish Odongo, aka the Son of Kano. My name's on all social media platforms, whether it's on X, on Facebook, on all meta platforms, is Dannish Odongo. Follow me, let us connect, let us have a conversation. Of course, the hashtag always is Manspeqtive Africa. Manspeqtive has a Q. If you just click on that, you can find all the snippets, all the shows, and all the content that we've put together by this since 2019 when we started this channel. It's been a long time coming. And of course, until next time, if you're watching us on YouTube, we are on KTN every Wednesday night. And if you're watching us this night on KTN, we are on YouTube, and the channel is Manspeqtive Africa. You'd be happy if you subscribe, because then you get to get fresh content before the general public gets it. Until next time, I'm your host, Dannish Odongo. Adios, and may God bless you.